I think this last lecture will be best practice in diagnosis and managing clean 2. It will be presented by Prof Brahim Tabaraki. He is a pediatric at Military Hospital Riyadh. You are welcome for your presentation.
For your introduction, and it's again my pleasure to be with you. Dr. Ali gave me the privilege to be yesterday. I am not the last, today also I am the last. Yeah. So we are in the treatment session, and I will speak about specific disease which is common again in the region, in the South Asian, which is clean 2. So this is my disclosure. So I have speaker agreement with Bible, and I will focus mainly on 2 main parts. The first one is about advancing the diagnosis, and the second part is what we can do for those patients in terms of treatment. So just to remind you that NCLs or neuronal ceroid lipofuscinosis are common in the kingdom. We have at least 13 cases with a molecular diagnosis. The type 9, still we don't have genetic diagnosis. So are mainly seen in children and with severe phenotype in terms of epilepsy, in terms of neuroregression and other manifestation, and are characterized by deposit of lipopigment in the neurons and in the retina, which causing neurodegeneration and also retinal involvement. So one of the common NCLs in the kingdom is CNL2, which is a genetic disease, recessive, autosomal recessive, caused by variant in the TPP1 gene, and this will cause deficiency in the TPP1 enzyme, and this will lead to the deposit of lipopigment mainly in the neurons and the retina, and this will lead to accumulation and neurodegeneration. So what about the diagnosis? And I think this is extremely important to have the diagnosis as soon as possible, as now we have disease-modifying therapy for this disease. And the diagnosis is mainly based as a clinician on the clinical phenotype. So we have to recognize very early the red flags for CNL2, and these red flags are mainly 2. So this is one is the patient present mainly with seizure between the age of 2 and 4 years. So most of the time is unprovoked seizure in a patient between 2 and 4 years. And what is extremely important, what we know today, that language delay is an important feature of those patients. So whenever you have a patient with early language delay and he presents with seizure, think about CNL2 and test about for this disease. EEG and neuroimaging are very helpful for the diagnosis. So this is a typical EEG for CNL2, and what is typical is the IPS, intermittent photic stimulation. So you see that the first part of the EEG is normal, and what's in the blue is the photic stimulation. So once we start to apply photic stimulation, but it must be at low frequency. Usually in the department of EEG, we start at 3, 4, 5 Hz. No, we have to start at 1 Hz. So 1 or 2, maximum at 3, you will see these discharged at every stimulation, and this is seen in around 70 to 80% of patients with early onset CNL2. So EEG can be very specific and early red flags for patients presenting with non-specific symptoms and signs as developmental delay or language problem or first attack of seizure. And the first important is to tell the technician to do the EEG with IPS at low frequency. So the second, which can help us in this non-specific presentation, is the neuroimaging. And you see that the first MRI is only we have subtle change. In the first one, you have the cerebellum is small, a bit small. You have some hyperintensity in the second one, and very mild brain atrophy in the third one. If you compare this early stage to the late stage, you see here we have advanced CNL2 with severe atrophy in the cerebellum, in the brain, and in all area of the brain. So to summarize, the first other tests that may help us and usually are abnormal before the clinical presentation are the visual involvement in terms of visual evoked potential and ERG. Usually visual evoked potential and ERG are abnormal before the clinical presentation. So with this is the classical type, so what we call before the late infantile classical type of CNL2. We recognize now that there is another group, around 15 to 20%, they may present at any age with variable presentation. And what is interesting in this group that the main presentation is gait problem in form of ataxia and cognitive decline. However, what we see in the first group, which is seizure and visual impairment, are rare in this group. So here also, if you have a patient with progressive ataxia and decline in his motor milestones, you have to think about CNL2. So, because the presentation is non-specific, so early language delay, seizure, these are non-specific. Most of the time the diagnosis is delayed, and at least for our patient, we have a delay of 2 to 3 years. So we have to think about, we have to test, how to test. We have two core diagnostic tests. The first one, the enzyme, can be done in dry blood spot, typically one, and the second is to test for genetic, whatever by single gene or by NGS if possible. So to summarize this diagnostic pathway, we have the most common group is the early infantile, the late infantile, between the age of 2 and 4 years. The patient will present with seizure, but he's already known to have language delay. If we do EEG with IPS at low frequency, you will have discharge, mainly in the occipital area, and if you do MRI, you will have subtle change, mainly in the cerebellum. So those patients have red flags to be tested, and we can do the diagnosis by enzyme and genetic testing. So before moving to the second part, which is the treatment, so let us see what is the natural history of patient with CNL2. So, and you see how rapid is and fast is the regression. So usually they start at the age of 2, and you see by the age of 6, 7 years, the patient is already on wheelchair. So very fast regression. You see in the first picture at the age of 3, how the patient is smiling, is bright, and at the age of 5, is already severely delayed in terms of epilepsy, in terms of dementia, in terms of ataxia, in terms of motor decline, etc. So very important to catch those patients as soon as possible, because we have now disease-modifying therapy. So one of the scales to monitor those patients, we have several scales, but usually we use this one, that what we call the Hamburg scale, which is 2 main parts. One is about the language, and one is about the motor. It's scored from 0 to 3, so you have the 3 is normal, and so if you have 3 plus 3 is 6, this is the normal, and after that, the 0 is the most severe. So it's very easy scale, especially for treated patients, we can monitor the response to treatment. So very important, as I said, to recognize the red flags and to test as soon as possible for this disease, because it's, the deterioration is extremely fast, and if we apply treatment late, probably will not gain anything. So what about the treatment? Again, this is a rare disease, so it needs special expertise. We have to refer the patient to a team familiar with this disease, and multidisciplinary team is extremely important, including physicists, metabolic, neurologist, epileptologist, GI, dietitian, etc., rehabilitation. And this is to maintain as much as we can the function and the quality of life of such patient. So what about seizure? So most of the patients have difficult to treat seizure. So the most important in treating seizure in such patient is not to look for the best anti-seizure medication, but to avoid the anti-seizure that may worse or trigger new seizure. And we have all the list of phytitoid, carbamazepine, ox, and vigabatrin may worse the seizure in those patients. So we have to use in the left, levetiracetam may be a good choice. More and more, if the patient has myoclonus, we are using the last, the one in blue. Pyramidinol is shown to have very good effect on myoclonic seizure in patients with NCL. So the other important news is the disease-modifying therapy, which is available at the market since now a few years, approved by European Agency and FDA since 2017, which is enzyme replacement therapy. It's a human recombinant TPP1, and this enzyme replacement therapy. So we have the chance to treat one patient. So we need to insert by the neurosurgeon a reservoir, which is intracerebral reservoir connecting the intraventricular. So it's what we usually we do what we call Omeya reservoir. The neurosurgeons are familiar with this, and it's very easy to be done. So, and every 2 weeks we are giving infusion via this reservoir to the intraventricular system. The dose is 300 milligram. So this was evaluated in international multi-center study, open label study, and you see that in blue the treated group, which are 24 patients, and 42 patients in the non-treated group or the natural history group. And you see in the red, so the natural history group with continuous deterioration in all domains. The treated group, the patients are stabilized. So no more regression if we start the treatment. So usually the indication is the score is 3 and above, 3, 4, and if we have better score, the outcome will be better. So the treatment efficacy also is sustained over many years, and the last paper last week, after 7 years follow-up, showed that the treatment efficacy is sustained after 7 years of treatment. So regarding safety profile, and the study showed that is associated with minor side effect, and most of the patients tolerate very well the treatment. For our case, we were afraid about the device-related complications, so the risk of meningitis, the risk of infection, but fortunately there is no additional risk for such patients. So again, CL2, NCL are common in the region, mainly in the south. CL2 is common, but we have to recognize as soon as we can with the red flags. The red flags are mainly 2, early language delay, and the patient will develop seizure between the age of 2 and 4 years. EEG is an important tool if we did it in standard condition with IPS at low frequency. MRI is also, but we have to test for enzyme on dry blood spot and for genetic testing. And because with the disease-modifying therapy, with the enzyme replacement therapy, sarcolephinase alpha, we can modify the course of the disease. And thank you very much.